I'm David Moliterno, one of the associate editors for JACC Cardiovascular Intervention, and joined today by a good friend and colleague, Dr. Antonio Colombo, who's from Milan, Italy. And we've got an important topic, one where we wish we had more data, but oftentimes don't, and that's outcome following intra-aortic balloon pump. So, Antonio, tell us a little bit about why you did this study and maybe give us the beginning of it.
But we wanted to really look at all our experience. This is more than 10 years experience with usage of balloon pump. Unfortunately, this is an observational study, it's not randomized, but you know, many times that's the way you get some useful information.
Sure, but you nicely went backwards and looked at cases who either had the balloon pump placed before elective PCI, emergency cases, and then urgent ones where you wanted it before a PCI.
Yeah, and you know, as I would say, as expected, the people that had elective did the best. The people that had the need for some complications had some more side effects. This is nothing so new, but points out that you should really do an effort to predict who is the patient who may need and not rush and put the balloon pump in an emergency.
So that's part of the challenge right there, is that, like in your study, roughly half the patients had elective balloon pumps. Then you have time to think and to make sure they're not going to have any complications, but roughly a third of them were urgent procedures where you don't always have a lot of time. So is there any messages or any takeaway about what we should do with those patients?
My simple message is that if you think, should I place a balloon pump in this patient, if this question comes to your mind, maybe you should do it.
Yeah.
So this is very, but I think it's better, especially nowadays, you have 8 French, 7.5. You don't need to keep the balloon pump long. After the procedure, you can remove. We have closure devices. But I think then you want to keep the number needed to treat as small as possible, but you cannot, you should not blame yourself because you placed the balloon pump in someone you could have done without.
Sure, and I think that's an important point. Oftentimes you get the sense somebody's hemodynamically unstable, it's a complex lesion.
Yeah, when you feel that sense, I think you may make the mistake towards doing.
So I remember that roughly a third of the patients had urgent procedures, and of those, roughly a third had a TIMI major or minor bleeding. So it is important, though, to pick out our patients who need them versus who don't need them.
And you know, some people at that time had more liberal use of 2B3As, higher dose of heparin. Now we really take the bleeding issue in more consideration, and we are not just 10,000 units of heparin on everybody. We do weight-based heparin. We don't want to overshoot with the ACT. Especially in the United States, bivalirudin is a good alternative. So I think the bleeding issue should not be put on the blame on the balloon pump always. It's also toward liberal strategy that was in favor at that time.
So excellent point. Roughly 20% of patients had bleeding, but it looked like those who were more likely to have bleeding had renal dysfunction, probably meaning they were having hypertension, older, and the balloon pump was left in longer. But I like your last point. Probably things have changed over this 10 to 12 year period, and so hopefully the bleeding rates are even better than in your observation. So really excellent points. I encourage people to take a look at this paper. Again, Dr. Antonio Colombo and myself, David Moliterno from JACC Cardiovascular Intervention.